Our next speaker is, our next case is being presented by Dr. Rory. Thank you.
All right, thank you. My name is Basil Rory, and I felt like, I have a number of cases, but looks like we're hammering on the cervical spine. So I thought, let me bring this up. So, 56-year-old female, 10 years ago, before this, she had a car accident, had a C7 corpectomy, and then 3 years later, she had throat cancer, had surgery, had radiation, and chemotherapy. And a few years before this, she was a smoker and she quit. And she comes in because if you look at her, she can barely take a deep breath. She's been sent by her pulmonologist because her pulmonary numbers are pretty bad. She is constantly having infection, and essentially she's going to suffocate to death because her neck is touching on her chin, and she can barely take a deep breath. And she's also lost 15 pounds over the last 30 days because she's feeling like something is pushing on her throat, she can't swallow. This is the preoperative films. Anyone wants to take a stab at what she did? Okay.
I would have hit her and put her in traction for a few days. Try to get her as best I can.
All right.
And I would recheck the X-ray at that point and make a surgical plan.
Okay. So I didn't have all the films, but if you look at her CT scan, she has jumped facets and 6, 7, which are fused. So she cannot reduce with the help. If you lay her flat, she has a fixed deformity. Her head doesn't fall back. Yeah. She's intact. She's walking.
She comes to clinic like this.
Would love to see her CT scan.
You have a scan?
No, I don't know. I can't see.
Okay, so she came in and stuff essentially that.
Right.
The jump is infused.
Right. Now, the plate is kicked out. If you did on the CAT scan, the plate is kicked out. It's pressing on the esophagus. And she's lost 15 pounds in the last 30 days, I think. She can't swallow.
You get a swallow study or an esophagram?
I don't recall that. We got her pulmonary numbers are pretty bad though. So we decided to just stage before and admit her. After 18 hours, this is what we have. So we did a 540-degree case. Because the facets are fused, we know we couldn't straighten the neck with the fused facets. So we started with her prone in kind of a Concord type of position. And we did laminectomy at, I think, pretty expensive, from C4 all the way to T1. Then we drilled all the facets. After we drilled all the facets, we placed our screws. And then we closed. Then we put it back. We went supine. We removed the other plate. We did a fresh corpectomy. Placed a titanium cage with allograft inside the plate. And then we closed that. Then we flipped her back. And put her on. Now she was pretty straight. So that's the post-op day 1 CT scan. She looks very good, and she comes back a few weeks later. The incision looks great. And she's feeling very good. She's happy that she's able to see up, she's able to take a deep breath. Her swallowing has improved. She just feels like she has a little hump on her back. So you take this. Okay, please, somebody say something. Yes. Pardon? Yeah. So, what do you think we'll find before we aspirate? Seroma? Okay. On a contrast study, it's ring enhancing.
Can you go back one slide, please?
Okay.
So just a couple comments. So you did 18 hours of surgery, you said?
Yeah.
Is there any ideas or preference to stage this? Is there a marathon session?
I'm just having a great day.
You said I love girls would be 12 times in kids.
Well, it was a pretty smooth case. You know, everything was planned and just laid out the way it did.
It's not the certain stem I worry about. Whenever I do a T4 pelvis or requiring big corpectomies and correction,
Right.
I start staging them, not for certain fatigue, but more for reasons like infection and things like that. There's data out there that long OR time, greater blood loss, you have immunosuppression to some degree, because you're essentially bleeding on your white blood cells that are working. You're transfusing blood. Transfused blood particles, it's a very, very, very good volume standard.
Right.
The immune cells have no real function, and they're usually washed out because of their fever.
Right.
So it was over 18 hours. What was your EPL?
600.
Total? Yeah. Well, that's not bad.
Now, if I was doing a T9 to pelvis, I'd probably stage it.
Yeah.
But
And the other worry was, is there give a better cut of the screws and the plate on the left?
Yeah.
Even the disc space there of 6, 7. It looks like there's a kyphosis there already on postal V1. I'm a little worried about that.
well, 6, 7, there was a plate before. There was a plate before, and like I said, posteriorly the facets were fused. So now we've drilled the facets. We've been able to extend her.
So the fusion's gone now. You do the facets back.
Right. So we drilled facets, I think, from C5.
Yeah.
Yeah.
So that 6, 7 now is no longer fused as it used to be.
Right.
It's broken up in front. So I was curious. Yeah, so there is a plate up front, correct?
Right.
And those screws are similar in the two body somewhere.
Then there was two.
Okay.
Yeah.
It's just that angulation concerns me. Certainly now the fusion's broken from the back. So I wash out the patient obviously.
Right.
Wound back, give them a chance. We probably send PJK the next slide, basically. And as you said earlier, Dr. Rohr, more screws.
So she comes back. Now this one right here, this is a vertebral body. You have 2 screws which are in 2 different vertebral bodies. Now we're meeting together.
What's the exam?
She's intact. She's just not out of pain. But she should always come to clinic walking, wounds healed. She's happy. She's just out of pain.
Would anyone, so you did a washout, correct?
Yeah, so I need a washout.
And this is after, how many days after the washout?
This is 3 months. Hold on. That was in November.
And MRI showing active osteomyelitis
MRI showing active osteomyelitis and
on these X-rays, right?
yes, no, this is CAT scans. MRI showing active osteomyelitis.
Right, from this, the data of this image.
Yes.
So would anyone take out the hardware like Dr. LaBelle recommended for a CTLSO, let her heal from an infectious disease standpoint, when she's completely healed, then take her back and correct her, do a large deformity correction, again. Also, again, do after that again.
Right.
And that's something I would consider. She's active osteo, putting more screws, it's gonna get me in trouble again. Take everything out, rigid brace, and then let her cool down for at least 12 weeks, that infectious disease do their thing, and then re-scan her, and then make a new plan.
So now, what rigid brace do the folks use for the thoracic spine?
I think you use Minerva or something like that, CTLS. I have a custom brace guy, and I'll make a custom brace for us with the curve I want sometimes, especially like, the deformities I want to progress, to avoid large deformity corrections. They work pretty well, and also sent to physiotherapy. I believe physiotherapy is something I would like to say, that work on strengthening their back muscles to improve their vectors, force vectors, tilting over. It's a difficult case. There's multiple ways of approaching it. That would be my approach, I think.
Do you think problems with the lumbar side?
Yeah, so all my patients, in their intake, it's scoliosis. Not just because they're deformity, but it's because I've gotten used to looking at them so much now. And I know the literature is going pushing more towards just concentrating on the sagittal balance, opposed to correcting coronal imbalance and things like that, which I do agree with. I also agree that we do overcorrect sagittal balance now. I think, I know there's a paper came out, it was high, I forget what it came out, where they said that after 50, you can tolerate 5 to 10 centimeters SVA per decade. And then we overcorrect and pull out the screws because their spine wants to be there. So you say you should only correct about, taking that into account, don't overcorrect to get a perfect x-ray because they'll pull out. So, on call, I've taken some patients that have had deformity correction, perfect and post-op scan, and he came out with all the screws pulled out the top because their spine wants to be there. So now, this year, I started doing less perfect x-ray correction, just a little, enough, not too much to prevent that screws flying my automatic as well. Who knows, next year I'll probably some PJ case of them, give them time. That's anyone else have an approach? Dr. LaBelle? Let's give you the microphone.
Sorry. Dr. Rehari, with Dr. Patel, I look at the entire spine as one functional unit.
Right.
And we too often look independently at the cervical-thoracic junction away from the, true sagittal balance that an individual has and where they want to stay naturally. So the problem is she originally had that corpectomy and then she had an absolute failure, which gradually occurred, causing dysphagia and her hypoxia. So with that in mind, yes, doing correction looked really, really good. But the first thing I would consider is to stage it. I would just have done an anterior fixation and then let her heal, let everything settle down before going in posteriorly. Also, I would consider, where's the problem? Where does she want to be naturally? Because of the fear that you can get an infection from a long surgery with a long instrumented posterior fixation. And, what are you going to do once those screws pull out? You're going to keep extending and extending. I know we haven't seen the end story, which I'm looking forward to. The other thing is giving sometimes a holiday for instrumentation is something I see a lot of these deformity orthopedic guys starting to do, watching the segmentation rooms and then allowing these patients to settle down. So, once you get into the cervical-thoracic junction, I think you're in just as much trouble when you start getting failures as you get into the thoracolumbar junction.
So, all those comments are well taken. Initially, when I looked at this case, I thought of just doing an anterior and putting in a hill. But with the facets being fused, there's no way we're going to avoid a posterior procedure. And then I thought, okay, if I go posterior and drill the facets, you cannot not do a posterior procedure. So we're pretty stuck from the beginning of going posterior. You know, it's one of those patients who've had chemotherapy and radiation, and we hope they come to your partner's clinic, not your clinic. So anyway, in case of time, let's move to the close to the end. So instrumentation. Now, you know, just the comment on the surgical, the balance. Whenever I have anything that's half looking like difficult, I'll get a full skull X-ray. And if you look at her X-ray, her lumbar is pretty good. She's pretty well balanced. She has a little bit of a thoracic. Her thoracic is a little bit straight, but in the setting of a cervical thoracic junction kyphosis, you can't quite judge the lack of thoracic kyphosis on that. Because for all those years that she's been going like this, she has to correct. And so she's been correcting, and her thoracic kyphosis is essentially kind of gone. Because, you know, she's going like this, and so she's pulling. But anyway, we ended up doing this, and thank God our story ended, not like Victor's story. But 1 month post-op, she looked great. 4 months, she looked pretty good. And 1 year from revision. And
notice your X-ray didn't show the bottom.
Okay. Well, 1 year from the vision, she's doing pretty well.
Her presenting symptom was dysphagia, was that?
Well,
I'm confusing people. We had so many, you know.
Well, dysphagia was one of them. So she has dysphagia, she is myelopathic, and she's hypoxic. And she can't swallow. She's lost 15 pounds in 30 days because she's not on eating.
So that improved.
Yes, she actually gained weight. Now, because she had a history of throat cancer, we did a full cancer workup before we started. We checked the bone density. We took her to a nutritionist. All of that.
So her, so do you think the weight loss, dysphagia, the hypoxia was from
Can we use the mic, please?
the corpectomy kicking out in the beginning? Like,
The hypoxia was from the deformity of the corpectomy kicking out.
and this is a question for Dr. Gala, who, you know, would you appreciate his experience? All her symptoms seem to be coming from that plate kicking out.
Right.
Would you just fix that?
But you couldn't have fixed that because you could correct her.
Right.
Have her sense of use posterior.
I understand. I would have done what you did. I'm just curious, Dr. Gallagher, I do appreciate it. Thank you.
But you also emphasized that she was becoming hypoxic from.
Yeah. This potentially wasn't hypoxic.
I mean, the first thing I mentioned was maybe getting an esophageal and a swallow study to determine whether or not her throat cancer or anything else. If she had a stricture or something very simple, right?
Right.
So sometimes it's not always, you know, the mechanical issue at hand. She could have had a bad looking construct that happened to be fused in a bad position,
Right.
and had esophageal stricture, and she gets dilated, and that's gone, and you're done. But you know, you clearly presented a patient who was having neurologic problems, the dysphagia, and also respiratory problems. So those are, you know, all of the other things that are indicating that her spine was collapsing over, you know, various systems.
That is the conclusion of the first day of this symposium. Thank you very much, Dr. Rowery.